Now, put that away. What can I do to you? Sorry, little Freudian slip there. What can I do for you?
I'm here to discuss my father's therapy options.
Yes, of course. Before we get started with that, I'd like to read to you some general information on strokes that I got off of WebMD. I mean that I downloaded from my own personal files, so you can better understand what's happening to your father physiologically. Here we go. Yes. Here we are. First, let me say that roughly 800,000 people suffer strokes here in America every year, that it's the fifth leading cause of death, and it kills over 130,000 Americans every year. Now, a stroke occurs when one of the main blood vessels that carries oxygen and other nutrients to the brain either ruptures or becomes blocked by some type of clot, normally a blood clot. When this happens, this part of the brain that is supplied by that vessel becomes cut off from the systemic circulation, which means that those brain areas are no longer getting the oxygenated blood they need, and they die. Now, to help you understand why your father is experiencing the symptoms he is, you first need to understand that the effects of a stroke vary from person to person and depend on the type, severity, location, and number of strokes that patient has suffered. And that the symptoms a patient exhibits depend on which portion of the brain the stroke occurred in. Are you following me so far?
I think so.
Great. Now, a stroke that occurs in the brainstem is usually caused by penetrating artery disease, which is a disease of the small blood vessels that branch into the major arteries, that branch from the major arteries into the depths of the brain tissue. This affects breathing and heart function, the ability to chew and swallow, as well as the body's ability to regulate temperature, which are all vital life support functions. So this is the type of stroke that most commonly leads to paralysis, comas, and possibly death. Now, your father is still alive, correct?
Of course he is. I wouldn't be here if he wasn't.
Okay, well, there's no need to get snippy. Okay, the final area of the brain where a stroke can occur is the cerebrum. The cerebrum is divided into right and left hemispheres and controls things like movement, speaking, thinking, reasoning, memory, vision, and emotions. Now, because the cerebrum is divided into right and left hemispheres, the patient suffers different physiological effects depending on what side of the brain that the stroke occurs on. A right hemisphere stroke will cause weakness, paralysis, sensory impairment on the left side of the body, as well as certain memory and behavioral problems. A stroke occurring in the left hemisphere causes weakness, paralysis, and sensory impairment on the right side of the body, as well as it inhibits your ability to understand language and some impaired function when it comes to math, reading, and writing. Now, does this sound like your father?
Yes.
Excellent. Now that we've settled that, what can I do for you?
You can explain the therapy options available for my dad.
You know, I could if I was a doctor, but I'm not a doctor. I'm just playing a doctor in this zero budget PSA because, well, I want as many of those 120 points as I can possibly get. Looking at you here, Neil. And so I can introduce you to my group subject matter, which is, of course, strokes. And so I can tell you that the purpose of the remainder of this PSA is to assess the effectiveness of 3 different types of stroke therapy that our group found in published scholarly journals. And to do this, let me introduce the next member of our group, Laura.
According to Archives of Physical Medicine and Rehabilitation, patients who suffer from a stroke, only 40% of those patients regain partial ability to use their upper limbs, and only 11% of the 40% recover completely. In the randomized control trial, the ACRM tested upper limb isokinetic strengthening rehab programs versus a passive mobilization rehab program. Now this study had 2 different groups. The first group was a controlled group. The control group consisted of those who performed the passive mobilization. Patients in this group used the dynamometer for about 45 minutes and exercised their elbow and their wrist muscles in the range of motion that was already predetermined prior to the start of the experiment and the exercises. Patients specifically had a kind of a vigorous, more of a vigorous program than the control group. These patients had a 10-minute warm-up of 3 to 6 reps of the flexion and extension of the muscles at the wrist and the elbow. And then after they did their warm-up, they would also do basically like their core rehab, what they were trying to work on. This consisted of about a 30-minute strengthening session with 6 to 8 reps of the flexion and extension movements for the muscles at the wrist and the elbow. So it was kind of the same thing repeated. Even though patients in the 2 different randomized groups received 2 different rehabilitative treatments, they did have some commonalities. For instance, along with the randomized prescribed rehab programs, patients also received various treatments in addition to their already, randomized prescribed treatments. Some examples of this would be balance exercise, manual strengthening of weak muscles, cardiorespiratory reconditioning, and walking, and even walking training, learning how to re-walk. Because a lot of times when you do have a stroke, it doesn't just pinpoint, oh, I'm just going to go to your upper limbs and affect your upper limbs. Majority of the time, it's all one side. Now, patients received these rehabilitative treatments 3 days a week for 6 weeks total. Patients were then assessed using 2 different tests in which they were assessed at the beginning of the rehab treatment between day 45 and day 60. And then they also were given retention tests at 3 months and 6 months post-rehab program. The first test that assessed sensorimotor impairment was the upper limb Fugl-Meyer assessment test. In the upper limb Fugl-Meyer assessment, patients in the control group who performed passive mobilization showed greater improvement than the experimental group. An assessment test was a box and block test. This assessment test consisted of grasping, moving, and releasing a maximum number of cubes that were 2.5 centimeters big from one box to another in 1 minute. And this assessment test was used to assess gross grasping capacities. In the box and block test, patients in the experimental group who performed isokinetic strengthening showed greater improvement than the control group.
My scholarly study was a study done by Daniel McDougall into the ideas that intensive inpatient VR-based exercise could be used to make a program that would challenge dynamic stability, promote mobility. The study was a blind study. It ran parallel group randomized controlled trials. Patient requirements were that they be 18 years or older, be able to stand on their own unaided for 1 minute, and that they be able to provide consent. Training consisted of 12 30-minute daily VR sessions, either skiing or soccer, over a 3-week period, using both a treatment group, 30 patients who did the trials standing, and a control group, 29 patients who did the trials sitting down. Clinical assessment of balance and mobility were completed 3 times: before training, after training, and 1 month after training. Improvement was measured using TUG, time up and go, Berg's balance scale, and a 2-minute walk test. Both groups showed improvement. However, the treatment group showed the best change in mobility and balance after the 3-week period. However, the difference between the control group and the treatment group was not significantly high enough to be relevant. Looking at their data, one of the limitations that the study says it has was that they believed they were underpowered. They believed if they had 20 more patients in both groups, they would have been able to find a statistical significance between the 2 groups. Another issue was that the patients that they were using for the study were of higher function. They were higher function stroke patients.
Thus, they didn't feel like this could be generalized to all stroke patients. Though there was no significant difference between the two groups, both groups did improve enough to show that for balance, VR exercise could be a positive addition to inpatient stroke rehabilitation. Would I recommend VR exercise programs to patients? I feel that, if anything, VR exercise for patients could be beneficial for no other reason but the fact that in a normal rehabilitation program, you come in, you do the same exercises or similar exercises in kind of a boring clinical atmosphere. With a VR, you come in, and each time you come in, and each time you do the exercise, the environment changes. Yeah, technically you're doing the same exercises, and yeah, technically you're still in a clinical environment. But in retrospect to you, the environment changes. And so you can find yourself doing the same exercises, but you're doing them on a beach. You're doing them in the Himalayas. And that creates motivation, creates a little more drive, creates a little more focus, which helps inspire learning and improvement. Another good thing about VR exercise programs goes with this idea of gentile taxonomy. With the VR program, you can introduce internal variables into the environment, such as a soccer team or a ball or trees to go around or a hill to ski down. And inevitably, through that, you can modify the difficulty, promoting dynamic movements and dynamic stability in a clinical, safe environment. And this can be good for any patient. If you just simply have to get used to walking around on the street with crowds again, or if you're an athlete who possibly had a stroke and needs to get used to possibly being back on the field and having to watch so many variables. So I think VR would be quite an interesting program to implement into rehabilitation. The graph up above shows the results for the pre and post clinical assessment period for the 2-minute walk test, the tug, time up and go test, and the Chaddock-McMaster's stroke assessment scale leg domain, which were measured across both the training group and the control group. Furthermore, in comparing the two group post and pre periods, it allows one to see the difference in significant improvement between both groups.
So the article I'm going to be talking about today is titled Improving Physical Activity After Stroke Through Treadmill Training and Self-Management. Impact, a protocol for a randomized control trial. Stroke survivors have 3 times the risk of further cardiovascular events than the general population. There is strong evidence that physical activity has protective effect against stroke. It can reduce cardiovascular risk factors in people with stroke, and not undertaking enough physical activity increases the risk of recurring stroke. The study, an article, took 128 people and they measured physical activity, walking ability, cardiorespiratory fitness, and cardiovascular risk. They split them in 2 groups, the experimental group, and they're going to be both using, as well as the control group, gait training for 30 minutes, 3 times a week. So it has to be Monday, Wednesday, Friday, for 8 weeks. But experimental group will have high intensity treadmill training, self-management program, and then the usual rehabilitation, as well as the control group. But the control group will have the usual gait and train. So pretty plain in the control group, high intensity self-management program with the experimental group. So here's a graph of the 2 groups, experimental group and control group. And here's the steps. And how they measured that is using an triaxial accelerometer, and that was how they were able to measure their steps. And you can see right here the experimental group with high intensity and with self-management program, they were able to get about 6,400 steps compared to a control group that only had 5,200 steps. So you can see there's a big difference between the experimental group and the control group.
In conclusion, the main weakness in this study was that patients who were randomly assigned to the isokinetic strengthening on the dynamometer, 50% of these patients experience excessive fatigue. It is best to prescribe passive mobilization to stroke patients in rehabilitative programs, mostly due to the fact that it's a low intensity. You're not overwhelming them, and you're not making them really fatigue. It is also thought that function limitations of the upper limb post-stroke is due to more of dexterity and cognition deficits rather than muscle weakness itself.
In conclusion, my study, Virtual Reality Exercise Improves Mobility After Stroke by Daniel McEwen, which was one of the first of its kind, and purely focused on the ideas of how VR exercise could affect mobility, and thus did not cover any neurological aspects or biomechanical aspects. However, it did improve mobility. It did show that it can improve mobility. And another way that it also ties into class is through Gentile's taxonomy. With VR, you can introduce internal variables such as other team players and balls and environments, which increases dynamic stability and dynamic mobility. And that's mainly how it helped out.
In conclusion, high intensity treadmill training in chronic stroke survivors is really beneficial. Their motivation increased, focus and memory all increased. The neurotransmitter for dopamine increase in motivation. So intrinsic motivation, where patients felt really good and it drive them to continue their high intensity workout. Serotonin decreased depression, so that helped improve in their life. So that's one. It helped stroke patients to increase their enjoyment of life.